Now that we've gotten oxygen out of the lungs and onto the red blood cell, let's begin to examine pulmonary blood flow. Pulmonary blood flow is critical because the matching of ventilation and perfusion is essential to adequate oxygenation and carbon dioxide removal. In the next section, we're going to talk about pulmonary blood flow, and specifically how ventilation and pulmonary blood flow match to maximize gas exchange. Let's think about the pulmonary circulation. The pressures are lower than in the systemic circulation. The right ventricular's got a pressure of about 25 in systole, 0 in diastole. Compare that to the left ventricle, it's about 120 during systole, and maybe a little bit higher, 10 during diastole. Pulmonary artery's got a pressure of 25 during systole, 8 during diastole. The pulmonary arterioles have a pressure of approximately 12. Pulmonary veins, approximately 8. The left atrium's got a pressure of about 5 millimeters of mercury. The pulmonary circulation is high flow, low resistance. We need to remember that these pulmonary capillaries are fairly flimsy. So if there's an alveoli nearby that's very distended, it can actually block off the pulmonary capillary totally. Lung volume is going to have a large effect on pulmonary blood flow. If we had a situation where the arterial pressure were greater than the alveolar pressure, the capillary would remain patent. Blood would flow past normally, and a gas exchange could occur. The change in alveolar pressure with each breath is about 2 centimeters of water, which equals 1.36 millimeters of mercury. So alveolar pressure changes by about 2.72 millimeters with each breath. This change is noticed by the pulmonary circulation. So if the alveolar pressure is quite high, the capillaries can close. Where we see this is in the different zones of West. John West is a pulmonary physiologist and physician in San Diego, and his textbook is taught in many intro pulmonary physiology courses. If we're standing upright, the hydrostatic pressures is greatest at the bases compared to the apex. Zone 1 of the lung, which if you're standing up would be at the apex, is the area where alveolar pressure is greater than arterial pressure, which is greater than venous pressure. In these cases, there's no perfusion. This is an example of alveolar dead space. We can recruit this dead space by increasing the arterial pressure, as in the case with exercise. West Zone 2 is the area where alveolar pressure is where arterial pressure is greater than alveolar pressure, but venous pressure is lower than alveolar pressure. Therefore, there's only flow during systole. During diastole, the capillaries would collapse. To some extent, this maximizes the amount of time you have for gas exchange. Zone 3, which is in the base of the lung if you're standing upright, alveolar pressure is less than both arterial and venous pressure. Therefore, blood flow is continuous. There are going to be diseases that are going to affect the relationship between zones 1, 2, and 3. Zones 1, 2, and 3 introduce the important concept of ventilation-perfusion matching. We think about ventilation, or V, or perfusion, or Q. Both are given in liters per minute. If there's no ventilation in the area of lung, the perfusion to that area is wasted. Likewise, if there's an area of the lung that's not perfused at all, the ventilation to that area of the lung is wasted. VQ ratios help quantify how well we match ventilation and perfusion. And how well we do this determines our arterial PO2. Ventilation is greatest in the base and least at the apex, but it doesn't change that much. Perfusion also greatest at the apex and least at the base. However, there's a large change in perfusion as we go from the apex to the base. If we look at the ventilation-perfusion ratio, we can see that it's highest at the apex. The VQ ratio is an idealized concept, and it's averaged throughout the whole lung. When we think about abnormalities in VQ mismatching, we don't think about a specific V to Q ratio. Let's introduce the extremes of ventilation and perfusion to make this point. Let's give the example where the alveolar pressure is greater than the arterial pressure, the zone 1 of West. In this case, V over Q is infinity. Air in this unit is not exposed to blood. This is an example of dead space, and specifically it's the alveolar dead space we talked about. The other extreme of VQ matching is an idealized alveolar capillary unit in which there is no ventilation but normal blood flow. 0 V, normal Q, so V over Q equals 0. This is an example of shunt. The area is perfused but not ventilated. Blood is flowing through the lungs without being oxygenated, just in the same way a shunt occurs in the heart. All of our lungs have dead space and shunt areas. A lot of pulmonary diseases, however, magnify the effects and the problems that these areas cause. Now, we have several defense mechanisms to account for ventilation-perfusion matching. In the systemic circulation, if an area becomes hypoxic, we see vasodilation. However, in the lungs, it's the other way around. If a particular area of the lungs becomes hypoxic, there's actually vasoconstriction. This will allow us to redirect more blood flow towards areas of the lungs that have a normal oxygen level. Additionally, nitric oxide acts as a secondary messenger to try to vasodilate areas that are nearest to high O2. You can remember that nitric oxide acts as a vasodilator in the pulmonary circulation by remembering that sildenafil, or Viagra, is used as a treatment for pulmonary hypertension. In pulmonary hypertension, there's vasoconstriction of the pulmonary blood vessels that's treated by giving sildenafil, a nitric oxide donor. More nitric oxide leads to more vasodilation, whether it's to the lungs or to other tissues that you might want to take Viagra for. Remember the concept of airway smooth muscles? And I asked the question of why would you have airway smooth muscles that would bronchoconstrict? A reason for that is actually to help VQ match. Let's look at blood gases in relation to VQ matching. Just remember, as normal, arterial oxygen is about 100, arterial CO2 is approximately 40, mixed venous O2 is about 40, mixed venous CO2 is about 46, alveolar O2 is 100 or maybe slightly higher. Remember that alveolar CO2 equals arterial CO2, and remember that the atmospheric CO2 is close to 0. So if we look at a normal alveolar capillary unit, first let's look at the alveoli. The PaO2 in the alveoli, which we could calculate from the alveolar gas equation, is 100. The alveolar CO2, which we know is the same as the arterial CO2, is 40. We look at the blood, starting in the pulmonary artery, where we have mixed venous blood with a PO2 of 40 and a PCO2 of 46. After it passes the alveoli, oxygen and carbon dioxide diffuse, we have arterial blood with a PaO2 of 100 and a PaCO2 of 40. In reality, the PaO2 should be a little bit less than 100 because there's always a slight gradient between the alveoli and the arterial. Let's now examine the condition of dead space. In this case, we have normal ventilation to the alveoli, but no perfusion across the capillary that crosses the alveoli. So in this case, if we looked in the alveoli, the PaO2 would be 150 because we've got no CO2 to displace the extra alveoli, the extra oxygen in that alveoli. There's a pulmonary artery in the neighborhood of this, but this pulmonary artery is never going to reach the alveoli, so that the oxygen and carbon dioxide content will represent mixed venous levels of 40 and 46 respectively. If the dead space increases enough, the total surface area for oxygen diffusion will decrease, and therefore the systemic arterial oxygen level would fall, even if the remainder of units are normal. If this dead space increased, we could help by hyperventilating other units to get rid of more PaCO2. We could compensate for dead space by hyperventilating. Let's think about our compensations for dead space more. The hypoxemia can largely be corrected if we were to give supplemental oxygen. This supplemental oxygen will serve to increase the pressure gradient for oxygen to diffuse. This will be most noticeable in the non-dead space units, so in the parts of the lung that are healthy. Those healthy parts of the lung can compensate for the dead space units. We also would have hypercarbia as a result of dead space. We can compensate for the hypercarbia by increasing our alveolar ventilation, increasing our tidal volume and respiratory rate. Now let's compare this with the example of shunt. In shunt, we've got no ventilation, but normal perfusion, so that the mixed venous blood leaving the right heart returns to the left heart as mixed venous blood. Blood is passing through the lung without being oxygenated at all. This blood returning to the left heart without being oxygenated will be blue blood mixing with the red blood in the rest of the left heart. We can quantify how much blood is shunted by calculating a shunt fraction. This can be done by putting the patient on 100% oxygen and looking at how much their P arterial O2 increases. In patients with greater shunt, supplemental oxygen will have less effect. More blood is returning to their left heart without ever being oxygenated. Thinking about the compensations for shunt. If we were to give 100% oxygen, we can never fully correct shunt. For example, if 50% of a patient's blood is shunted, 50% of that blood will have a PaO2 of 40 millimeters of mercury. No matter how high you raise the rest of the PaO2 in the blood, you're never going to be able to compensate for that blood returning with a PaO2 of 40. Remember, the oxygen hemoglobin dissociation curve will govern this. Even though we're able to raise the PaO2 in the healthy units, where you're supplementing with 100% oxygen, to a PaO2 of 650, it's going to correspond with an oxygen saturation of 100%. We can't get it any higher than 100%. That 100% saturated blood will mix with blood that is saturated at about 50, corresponding with a PaO2 of 40 millimeters of mercury. So the hallmark of shunt is failure to respond to 100% oxygen. Now, we still treat these patients with supplemental oxygen, but you know the patient has a physiologic shunt if you're giving supplemental oxygen and their oxygen level doesn't get better. Let's do a question. A 66-year-old gentleman undergoes a pneumonectomy, taking out one whole lung for lung cancer. The surgery is going to cause a decrease in all the following except we'd obviously expect his diffusion capacity to go down because we have half of the alveolar capillary units. We would also expect his FEV1 to go down. He's got one less lung to use. His pulmonary artery pressure actually would increase. You've got the same amount of blood flow, but instead of flowing through two lungs, it's only flowing through one lung. So C is the correct answer. His total lung capacity, D, is obviously would go down because he's got half as many lungs. A patient gets a pulmonary embolism, a blood clot from his leg that goes to the lung and occludes a pulmonary blood vessel. If the patient doesn't change their respiratory rate or their tidal volume, we would see an increase in all the following except A, dead space. We actually would see an increase in dead space because the area downstream from where that blood clot was would represent ventilated units that are not perfused, the definition of dead space. We also would expect an increase in pulmonary artery pressure, B. In this case, the patient has the same amount of blood flow going through less of their pulmonary circulation, causing a relative increase in their pulmonary pressures. Shunt we'll leave aside and then talk about PaCO2. If the patient has more dead space and doesn't increase their respiratory rate and tidal volume, we would expect their PaCO2 to rise. So the correct answer actually is shunt. There's nothing about pulmonary embolism that causes a shunt. It causes pure dead space. There are 5 physiologic causes of hypoxia, and we're going to introduce these here. The simplest explanation for hypoxia is a decreased atmospheric oxygen level. We see this at high altitudes. It's usually fairly obvious from the question. If your patient's on Mount Everest, there's a good reason why they're hypoxemic. Another potential cause of hypoxemia is hypoventilation. In this case, there's no problem with the lungs, but there is a problem with too much CO2 in the alveoli. Too much CO2 in the alveoli displaces oxygen, therefore leading to a lower P arterial O2. The most common causes of hypoxemia are VQ mismatch and shunt. In general, if you're asked the question what the physiologic cause of low blood oxygen level is, the default answer is high VQ mismatch or abnormal VQ mismatch. This occurs in COPD, in pulmonary fibrosis, in pulmonary embolism, and pulmonary edema. Shunt is really an extreme example of VQ mismatch, in which case you've got areas of the lung that are perfused but not ventilated. We see this in the case of lobar pneumonia, we see this in the case of atelectasis, and we see it also in cardiac causes, such as a ventricular septal defect with a right to left shunt. Limited diffusion is another potential cause for hypoxemia, but it rarely occurs in and of itself. The hallmark of limited diffusion contributing to hypoxemia is that the hypoxemia occurs with exercise as opposed to at rest. That concludes our discussion of pulmonary blood flow and ventilation and perfusion mismatching. That was a tough section. Good job.